You're watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. This is a special edition. We're talking about bioidentical hormone replacement therapy for women. With us, we have an expert on the topic. We've had him on the program before, Dr. Edward Tangchitnob. Dr. Tangchitnob, welcome to the program.
Thank you, Randy.
Now, you are board certified in obstetrics and gynecology. So you see women every single day.
That's
you
correct.
And your father.
Me and my father, that's correct.
Now, for people that don't know your practice, like who's the typical patient that you see?
Well, Randy, as a board-certified OBGYN with fellowship training in robotic surgery, we see all sorts of patients in our practice. In fact, we treat the very, very young all the way into the menopause years, and so we have a very wide range of women that we see in our practice. Now, I would say that the typical patient who comes and seeks us and finds us is the 40-year-old woman who can't seem to lose weight. She's losing interest in libido, intimacy with her partner now, and really just has lost that pep in her step is often what we hear. These are typical patients that find us, they find us online, maybe they've done a little bit of reading beforehand on what we do and some symptomatology that they have. And oftentimes these women will complain that they're fatigued, they don't quite feel like themselves. Oftentimes they have this brain fog, this mental clarity issue, and they find us. They actually find my father and I in West Covina, California.
Now, this is like the new way of aging. You know, we were talking in the green room.
Right.
That I guess just getting old, losing libido, things like that. It doesn't have to be that way, according to you.
Well,
elaborate on that.
Well, you know, it's interesting because when I was doing my residency at Cedars-Sinai, I did the traditional OB/GYN residency. It was a lot of hours on deck in labor and delivery, and we were doing obstetrics. And on our rotations, some of them actually included laparoscopy, some hormone replacement, and I almost feel that when I graduated from Cedars, I got a big book, and that whole big book was called estrogen.
Okay.
And it was estrogen for this, estrogen for that, and don't get me wrong, estrogen is fantastic, but estrogen is just one of a few hormones that the ovary produces. But that's really all we're trained during our OB/GYN residency. And even in fellowship, estrogen took on a different kind of meaning. Actually, if you have too much estrogen, it could cause endometriosis or pelvic pain. And so somewhere along the lines, all we kind of were really trained on was estrogen. But there are other hormones that women need to feel.
Okay, so what are the commonly replaced hormones in your practice?
Well, estrogen, I mean, that goes at the top of the list because that's the one that most women know. But testosterone, that's also a very important one. Thyroid, vitamin D, which in itself is a type of hormone, often overlooked. These are hormones that are very important. Progesterone, which is something that's also important, needs to be replaced too. And really, it's, I think, the combination of all of these hormones that create a certain milieu or a certain effect. It would be as if going to see a doctor and then you find a deficiency or a diagnosis, and you're only doing or treating part of the problem. And I think that's what's happening when women are looking for hormone replacement and they're finding doctors that really just give them estrogen.
Okay. Yeah. Is that what's happening in gynecology?
I think so.
Is that who women go to typically for their hormonal problems, is the gynecologist?
Well, not always, right? So sometimes they start out seeing their primary care physician, but oftentimes the primary care physician is so busy and they're looking at all the other markers for their health, such as their glycemic index or high blood pressure, that oftentimes the hormone replacement aspect of it either goes overlooked or missed. And I think that, you know, if that first encounter is not set up correctly, women oftentimes leave and say, well, maybe my hormones are normal. But then they don't feel normal. And I think that's really the key take home is that feeling of not feeling normal, losing your pep in your step, that fatigue. And a lot of it has to do with how the hormones are playing with each other. Okay.
Now, at what point should women go see you?
Well,
at what age?
You know what, I've seen patients in their early 20s. There's a syndrome that I specialize in called polycystic ovarian syndrome. Do you know what that is?
No.
Well, polycystic ovarian syndrome really is a manifestation of the ovaries when they have multiple follicles or cysts, and this leads to insulin resistance. The insulin resistance that starts actually as early as 18 leads to hormone imbalance, and what that means for the patient really is that they just experience all sorts of symptoms. They gain weight, they have hirsutism, which is the medical term for hair growth on their face. Many of them have acne. You know, we do a lot of cosmetic as well as skincare procedures in our practice, and all of it has to do with the fact that there's a sequelae of acne.
So how could you have stopped that early on, that woman like you were mentioning?
hormone balance. And so the word hormone balance really refers to, again, get into that optimal state in which, well, in this case with the younger women that you're asking about, in their 20s, they need to really balance testosterone, estrogen, and progesterone. And between you and I, the quickest way to do it is put them on a birth control pill. But oftentimes we think that the birth control pill is really to prevent pregnancy. But there are a multitude of different benefits from the pill itself that these PCOS patients are experiencing. Some of them, once they regulate their cycles, begin to experience some weight loss. And then when you start pairing it with I call it the magic bullet, but PCOS patients with birth control and metformin lose weight. They start reversing some of the acne. They start reversing some of the weight gain. They actually become their optimal selves again. And that's just a great example, I think, of hormones really being pertinent to the younger group, which is in their 20s, all the way into what we classically know as the perimenopause or the menopause group. So hormones
give us
affect
a
every
working
group.
definition. So perimenopause is what, and menopause is what?
Well, perimenopause, so peri meaning near, so peri is near menopause. So that means that some of the women are experiencing some cycles, they're still having menstrual cycles, but it's more erratic now. They're having less energy, they're experiencing more fatigue, libido starts to go down because the testosterone begins to decline, but they're not yet in menopause yet. Now, two definitions of menopause. First of all, you could look at the lab values. An FSH, or a follicle stimulating hormone, more than 50, traditionally is menopause, or 1 full year, that's 12 months, no bleeding. And it's a pretty strict definition. So even if you had
So no menstrual cycle for a year, you're in menopause?
You're in menopause.
Okay.
Correct. So you have a
And what are the
lab
symptoms
value.
associated with that?
Well, in
Usually,
the way I break it down is it depends on the hormone, right? So estrogen is responsible for some of the vasomotor symptoms, so hot flashes, some mood changes. Some of my patients come in and they don't experience some of the hot flashes their mom did, but they can't sleep. So insomnia, that's a big one. Dryness. So dryness could occur in a variety of different areas. Vaginal dryness, so intimacy dryness, dyspareunia with painful intimacy. They get skin dryness. They're putting on all sorts of creams. They go down that aisle in CVS and they're trying everything, right? But really it's an internal dryness that's happening because estrogen helps control and create collagen and elastin, and that begins to decline. So the skin actually begins to decline. They're having hot flashes, what we call the vasomotor symptoms, and these really are estrogen dominant or estrogen related symptoms. They get bloating, that's a big one. Some of the patients that come in and their clothes are fitting differently are kind of hormonal mediated changes.
Okay, so what's the answer for these people then?
Hormone replacement.
You're giving them estrogen,
Absolutely.
progesterone, thyroid,
absolutely.
testosterone?
I think a combination of all of them. And it all depends on the labs, right? So once our patients come in, they come for a full evaluation, they go through the checklist. And I divide the checklist up into symptoms clustered by their hormone, right? So at the very top of the list are the testosterone symptoms, the libido, the energy, the inability to lose weight, mental fog, and then in the middle third are my estrogen symptoms, the bloating, the hot flashes, the insomnia. The lower third are my thyroid symptoms, and I don't tell them that. I don't tell them that's how I'm actually designing the review of systems.
All right.
But as they're going through, it goes from low to severe in terms of symptoms. And I've been doing this enough now that just kind of looking at the symptom cluster, I could tell almost which hormones they're missing.
Do you see reversals in these symptoms every single day in your practice? And if so, how soon does this happen? Like after you start optimizing their hormones, how soon?
Absolutely, and I think it's great. In fact, I recently had a 51-year-old come to my practice. She found me online. She saw some of the video testimonies from some of my other patients that I had posted, and she said, you know, that's me. I mean, I'm having hot flashes. I can't sleep. My periods are becoming more erratic, and so she came and we did a consultation for her. She filled out the review of systems. We then did a targeted lab draw on her, and we drew all of her hormones, including her vitamin D, and we brought her back, and I basically told her, hey, listen, these are the hormones that you're deficient in. So there is validity to what you're feeling. And once we began to replace her testosterone, estrogen, and progesterone, within a few weeks, she started feeling better. She said she had more energy, and I think some of it too had to do with the fact that she's sleeping better, and some of her abnormal urinary bleeding symptoms also improved. So within just a few weeks, we could see a reversal of the symptoms.
So they say, what, I feel better, I'm back?
They say that they feel like themselves again.
Okay.
And I think that's so rewarding to get to that point. Because when we're working in a society of medicine nowadays where we're almost chasing, we're trying to chase that next lab value, or there's a standard that we have to meet, like the hemoglobin A1C or the blood pressure, these are just numbers, have to be in a certain range.
Okay.
We often forget that there's a person behind these numbers. And I think it's really important to get back to that foundation again, to get the patients feeling better. Otherwise, we'll see that slowly with time, I think there's a loss of effect. Patients are like, why am I going to see the doctor if the doctor doesn't make me feel better?
Now, do most women know this, that bioidentical hormones, optimizing your hormones, is good for you? Or is there still controversy out there where they think, I don't know?
When patients find me, I'm very adamant about educating them on the differences between bioidentical hormones and synthetic hormones. And just like the name connotes, a synthetic hormone is a man-made hormone that is hormone-like in nature, but is not an analog of the true hormone, like a bioidentical. A bioidentical hormone, on the other hand, is made to look exactly like the hormones that your body produces. So in the ovaries, for women, for example, testosterone, progesterone, estrogen. When a bioidentical version of this is created, it's usually created from a plant-based source, and it's made to look exactly like what your body used to produce. For men, same thing. Testosterone can be created in a bioidentical manner or a fashion, and it's made to look exactly like what your testes used to produce.
So I understand this correctly. So you take a woman in her 50s. She's starting to miss her periods, menstrual cycles, things like that. Maybe PMS symptoms, libido's going down, maybe some brain fog, things like that. These women in their 50s, are you returning their hormone levels to that of a 30-year-old, 25-year-old?
I would say 25-year-old would be good. And you bring up a great point, Randy, because just last week I had a patient of mine come in, and she was 47, mother of 2. And when I started doing the testosterone piece, she was like, whoa. Actually, I don't want testosterone. I don't want to be turned into a man. Okay. And I started talking to her, and here's the education piece again. I asked her very simply, when you were 21, did you feel like a man at all? And she's like, actually, no, I felt sexy and vibrant. And I said, well, did you know that during that time your testosterone was actually the highest?
Is that right?
Absolutely, and that education piece, that connection, really, I think, enabled her to make the right decision. I ended up replacing her with testosterone, and she's done very well since. In fact, she wrote me an email and basically said, I feel great. So with her, I was so excited because she said, I got my life back. I feel like myself again. I feel vibrant. I have interest in libido.
Is that right?
Yeah, I have pep in my step, that desire to get out of bed. I have that again. And I call this the 6 p.m. test, right? I asked her, I was like, do you feel like going to the gym at 6 p.m.? And she says, absolutely. In fact, she has a trainer
Really?
now. And she's
Because of hormones?
Because of hormones. And because of testosterone. Remember, that was the hormone that she was so hesitant about, but that was actually one of the hormones that was used in the replacement of her program.
Now, let's start with testosterone. I don't even think of a woman having testosterone levels. What are the symptoms of a low testosterone, and what are the benefits of replacing testosterone when you're in your late 30s, 40s, 50s?
Right. So when I approach my patients with this consultation, testosterone is traditionally considered to be a male hormone. But testosterone is actually the precursor to estrogen, which is traditionally considered the
right? Okay.
female hormone. And in fact, you and I as men, we have to have a certain amount of estrogen in our system to be optimal. Too low estrogen, in fact, we actually have mood symptoms, right? So it's important, I think, in both genders to understand the importance of testosterone and estrogen as an interplay between each other. So going back to the question again, most patients will say, particularly women, that they have a decrease in their partner. So whereas before they come home, they say, they look at their partner and say, why did I marry this guy?
Okay.
After we do testosterone replacement with them, they come back and they say, he looks kind of good.
He looks pretty good.
He looks pretty good. And so that's a testosterone replacement or testosterone symptom. Other kind of benefits is the loss or the maintenance of visceral fat. So visceral fat is fat that's actually below the abdomen, the fat that actually pads the organs, and it gives you that kind of bloating effect. And depending on what your testosterone levels are, it's a hormone that actually could control how visceral fat is utilized as energy and as a fuel source in your body. So when testosterone begins to decline, what do you think happens to the lower abdomen? Well, it gets swollen, it gets larger, and so testosterone really is there to help in terms of metabolism. Also, in addition to that, women don't know that having a certain amount of lean muscle is critical. Critical
Okay.
for what? Well, it's critical for sequestering glycogen. That also helps with fat and maintenance of the overall attractive body shape. So testosterone is very important. And those are the things that they feel. For things that they can't see, testosterone all protects the heart. So did you know that
Does it feed the heart?
It will actually protect
Because
the
they
heart.
say you get more energy with testosterone.
Absolutely, and testosterone itself is vasodilatory, so it actually causes blood vessels to expand. So testosterone is great too in preventative symptomatology, right? Things you can't see. So testosterone also helps prevent Alzheimer's. It can also affect the
There's
bone.
studies to
And there's
prove some of
studies
this?
to do that. And
Okay.
when we think about that mental fog that we kind of talked about earlier, and patients will mean to do something, they get home, they're like, what did I mean to do again? That's really the beginning of that brain fog. Testosterone can help with that. It could also help with bone. In fact, testosterone, there are testosterone receptors all over the body. And so when we talk about testosterone as a hormone, what we're really talking about is the fact that it is protective of the body.
The next hormone, progesterone. What's it good for, and how are you using it with your patients?
Progesterone is great. I mean, traditionally, progesterone is known as the feel-good hormone. So for some of my younger...
Feel good?
Feel-good.
Okay.
Feel-good hormone.
Okay.
So for some of my younger patients who are anovulatory, that means that they're not releasing an egg every month, they get into very bad episodes of abnormal uterine bleeding. And the reason that is they're not producing enough progesterone.
Okay.
And so when I try to explain to my younger patients in their 20s and 30s, maybe they have polycystic ovaries in which they're not releasing an egg every month, the addition of a little bit of progesterone stops their bleeding. And the way I try to have my patients remember that is the hormone progesterone, have the letters PR in it, and so does the word protect. So progesterone actually protects the uterine lining. And the way it does that is actually works with estrogen. And so by balancing progesterone with the rest of the body, it protects the uterine lining and helps with abnormal uterine bleeding. Fast forward when you're 50, 51, and you start undergoing menopause, you're actually undergoing a similar process because again, you're becoming anovulatory, not because of stress, not because of weight, but now because the ovaries are actually giving out, they're actually failing, they're undergoing atrophy. So now the ovaries are not releasing eggs, and again, you're missing progesterone. And so you're not able to sleep. Oftentimes our patients...
So it helps with sleep?
Absolutely. It's actually one of the best sleep aids that I have. 200 milligrams every night before you go to sleep will get you a good night's rest in the morning. It actually rebounds into good energy for the whole next day.
So these are prescriptions, and they're made by what, a compounding pharmacist?
That's correct. And so, again, the cornerstone of our practice is bioidentical hormone replacement. So I don't use synthetic hormones in our practice. We try to get as bioidentical as possible, including thyroid and also including the progesterone that we use.
Now you say that the second half of a woman's life or man's life should be the best half of life. What do you mean by that?
Absolutely. And when you're younger, yeah, sure, you have energy, your hormones are optimal, but you lack wisdom, you lack kind of convention, and you lack life experience. When you get older, arguably, you might have more money, you might have more resources now.
Like the 50 plus crowd, 40 plus crowd.
But your hormones are going down. It's almost a cruel joke, right?
So your energy's gone.
That the energy is gone, but now you're in a place that you could actually spend, money traveling and enjoying life, but you can't really enjoy life as if you were 20 because your hormones are not optimal. And I think that disconnect now is something that our patients are really looking for in terms of quality of life. And so many of my patients, some of them actually, I'm delivering some of my father's granddaughters, kids, just to kind of give you a segue into the width and breadth of our practice, which is in our community. And so naturally, just by age, his patients are almost all of them are undergoing menopause or perimenopause. So we're treating them now, and it's just been so exciting to give them options, novel options, innovative options, in a way that I would approach a solution as an engineering problem. So if there's a deficiency here, let's find a way around it. Let's build a circuit to help.
So let me ask you a question. So when you replenish hormones to more youthful levels,
yes.
So not only do they feel better, do they feel younger? Do they also report that they feel younger?
Absolutely, and they look younger too.
Really?
I think an inner smile comes out. They have that glow again, and it's kind of hard to tell because many of them are now going to the gym. So is it they're vasodilatory and they have that nice flush because they have good blood flowing, or is that they feel so good now that they're choosing better diet options, right? No more emotional eating. Because emotional eating, I think, comes from the fact that their hormones are low. You feel down on yourself. Let me see if I could do this quick fix and eat this high glycemic burger and just, but they're not doing that. They're looking for ways to eat clean. Anti-inflammatory diet immediately comes to my mind.
So this is the new aging gracefully. Optimizing your hormones.
I think so.
Thyroid. I know you love thyroid, or at least that's what I picked up on the phone. So who needs thyroid, and what are the symptoms of low thyroid? And what are some of the results you're seeing?
I think that the thyroid is an often underlooked and misdiagnosed condition. Now, the technical word for, or technical phrase for what I'm really looking for are those patients who are sick euthyroid. So what sick euthyroid means is that your labs look completely normal, euthyroid, right?
Okay.
But you feel sick. You're gaining weight, you have low energy, you have cold intolerance, and that's many of our patients. And so I'm bringing patients in for a thyroid second opinion. These patients are being told by their primary care physician or another physician,
thyroid's fine.
Your thyroid's fine, but now they just gain another 20 pounds.
So is thyroid one of those things that they feel more energy?
Absolutely. It's a big one.
Okay.
Yeah, and so, not only does the thyroid affect energy, it could do temperature, regulatory centers of the brain, but it also involved in the basal metabolic rate of your body. That is how fast your body is moving.
So these pellets, you insert them, they have progesterone, estrogen, thyroid in the pellet. Where do you put it?
Actually, so to be fair, it's actually testosterone plus and minus estrogen in the pellet.
Okay.
The other hormones can be given orally, and you have to time them.
All right.
For example, my thyroid, I take pure T3. My thyroid's on my nightstand. So every morning I wake up, the first thing I do on an empty stomach is I take my 1 grain of Nature-Throid. Now, other patients might have different doses. It depends on really what the starting T3 is.
Okay.
Now, the rest of it, the pellet, as you were kind of speaking of, I don't have estrogen in my pellet, I have testosterone. But some women, particularly the true menopausal women, will have estrogen and testosterone. Now, the location of the pellets actually goes into the gluteus, or it goes into the subcutaneous fat of the leg, in the lower leg. And it doesn't hurt. It involves a 3-minute procedure with a little bit of local numbing agent, and it's done in just a few minutes. It's quite painless. For women, it lasts for 3 to 4 months at a time. For men, it's usually the husbands that now come in, lasts for about 5 to 6 months at a time. So we love it as a delivery system. It offers consistent, continuous hormone delivery without the kind of disadvantage of having to apply a cream or do a painful injection every 2 to 3 days.
Now, one of the things you said, and we literally have a minute left, but you treat a lot of women with endometriosis, right? Did I pronounce that right?
That is correct.
And also hysterectomies.
Yes.
You said before we started taping that with optimizing hormone, proper diet, you could eliminate most of these procedures for endometriosis that women are going through like every 12 to 18 months. So, is that right?
Correct.
How?
So I specialize in endometriosis, which is I hate this diagnosis for patients. It's a terrible condition in which patients, particularly younger patients, experience chronic pain because they have endometriotic implants in their pelvis that are susceptible to estrogen. So endometriosis has the letter E in it, so does the word estrogen. So I try to teach my patients that estrogen is actually causing endometriosis to grow.
Like too high?
Too high.
Okay.
So now you have too much estrogen, and so estrogen causes these to grow, and every month when the estrogen rises or raises during the menstrual cycle, pain is terrible, and then all of a sudden they have their cycle and you get some relief of the pain.
So how do you lower the estrogen?
Well, you actually lower it using different agents. You could use birth control pills, and and that seems contraindicated because estrogen is contained in the birth control pills, but it's all about the estrogen threshold hypothesis. And what this hypothesis says is that every woman has a different estrogen threshold in which if you lower the estrogen just enough, they experience pain relief. You do it too much, you put them in the the menopause state, they start having hot flashes, mood changes. So it's really the art, I think, of lowering the estrogen just enough to get pain relief. And then when do you time laparoscopy or robotic surgery? Well, all that goes into the shared physician-patient decision-making model, I think, between us and the patient. But now,
so you have women that are getting these procedures, laparoscopic procedures for their endometriosis.
Correct.
And now you've got them on a hormone program and they no longer need these follow-ups.
Well,
these other procedures.
They still follow up, but they're not following up with the intent of surgery. Because now we've armed them with education, knowing that estrogen can cause your pain to get worse. They now know and have strategies employed in place where they could lower their estrogen with certain injectables that we use, certain oral medications we use. And I actually, just a month ago, I remember I had a patient come in and she told me, she was 26, and she said, Dr. Tangchitnob, why is it that the very same hormone, estrogen, that's responsible for my fertility is also responsible for my pain? And I couldn't even look at her. I mean, I just felt so empathetic because I couldn't explain why the body was set up like that. And in that one moment, I realized how difficult it was for women to actually create this hormone that causes fertility, protects the heart. We talked about all the benefits of estrogen, but in a small subset of the population causes severe pain, infertility, not to mention some of the psychological
So with that
pain.
26-year-old woman, what happened?
Well,
Were you able to turn that around?
We ended up putting a small camera inside of her during laparoscopy, finding where her endometriotic implants are, and coming up with a short and long-term plan. And she wants to get pregnant in the next year, and that goes into her long-term plan too. And lowering her estrogen just ever so much that she experiences pain relief without having all the side effects of menopause.
So, final message to a woman that's watching this, and she's starting to get the symptoms that you mentioned, like brain fog, irregular menstrual cycle, maybe PMS symptoms, vaginal dryness, lack of energy, all of those things. But for whatever reason, they're still skeptical about bioidentical hormones. What do you say to them?
I would say education is paramount. I would say do your research, go online, try to read as much as you can about the differences between synthetic and bioidentical hormones, and come up with your own conclusion. Look for those stories, because a lot of it has to do with anecdotal storytelling. Look for testimonials. Look to see who's credentialed in your area and how many cases he or she has treated, and see what additional training he or she has had after residency. I would also urge everyone who is experiencing any of these symptoms. In fact, on my website, there is the checklist of symptoms that you could actually fill out to see if you're even a candidate for bioidentical hormone replacement.
And those could be reversed or stopped?
They could be reversed or stopped. We could have relief. And it's just such an exciting time, I think.
Do you think it could add years to your life? Is that your opinion?
I think so. And not only just numerical years, but we're talking about quality of life years. And I think that's going to be critical in the next decade of medicine.
Okay, good. So when they call, they get to see you?
Absolutely.
Or your father, either one?
Either one of us.
The dream team in West Covina?
I would say we all drank the Kool-Aid, right? So all of my staff were all treated with some kind of regimen. Our office manager, who
all the women are on hormones in your office?
Yes, everyone.
So they're all happy?
They're all happy.
Tons of energy?
They're feeling good, because we really want the world-class experience for our patients coming in. Particularly because in the beginning of the show, we talked about the patients who have fatigue, they have no interest in libido, and now they're coming into an office that may be making another promise. And so when our patients come in for evaluation, we absolutely want them to have a world-class experience. And so it really starts with the patient's experience coming in the office. You'll see that all of our girls wear purple or lavender. That's really our office color. And we're really about the experience, because I think we're creating a brand.
And by the way, your pricing, we have to mention, because insurance doesn't really cover this, but you're less, we were talking about, you're less than like what a personal trainer would be over 3 months. Or even Jenny Craig or Nutrisystem or some of these. So it is priced right. It's affordable for most people to do. And you do it right there. So,
exactly.
So thanks again for coming on the program. Good stuff. And if they want to learn more, they could go to your website.
Absolutely.
You have some stuff on there.
Exactly.
Some videos on there.
Some videos, information, testimonials. And I would just urge the audience out there to go out there and get their labs drawn, see what the levels are.
Okay, good. Thanks again.
Thank you.
Stuff. You've been watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez for now. I wish you good health.
Thanks for watching the Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.